My name is Dimitris. I'm a professor of biomedical informatics and data science here at Yale. This video is part of the supplementary videos for a new certificate program in medical software and medical AI. Our guest today is Riccardo Lampariello, who's a statistician by training. He has about 25 years of experience in healthcare. He spent 10 years in the pharmaceutical industry and then moved to the non-profit sector, places like GAVI, UICC, Terre, hommes. In 2022, he joined DTree as their CEO, and the mission of DTree is to expand access to high-quality essential healthcare by enabling better decision-making. He has vast experience, including clinical operations, portfolio management, business development, capacity building, and public health. In the last 10 years, he's been focused on adapting solutions, digital health solutions, to the unique context of developing countries and scale them successfully to the national level in Burkina Faso, India, and Zanzibar. We actually did record a video in Zanzibar as part of the certificate program we put a link to earlier. He also has substantial experience in data governance. His original background in statistics, then he did an MBA in the non-profit sector, but his life experience probably is more than his education at this point. So Riccardo, welcome. Tell us a little bit about you. How did you start? How did you get here? And then we'll get on to DTree and your work.
Yeah, thank you so much, Xenius, for having me. It's such an honor for me be part of this this certificate. So, I mean, as you pointed out, I started in the private sector. I worked as a statistician initially in the pharma, looking at clinical trials and see if the drugs, the new developed drugs, were effective and safe. And I was really proud of what I was doing because I was really making a difference in people's life. So that was really a tremendous experience. And then I started also look at that most of the drugs, the treatments that we were actually building, were making, they were for the benefits of a small part of the population. There is still a huge amount of people that don't get essential basic treatments. So with that in mind, I also realized that there are drugs out of patents. I mean, essential drugs like insulin that could still not be administered to everyone. There was a problem of access to medicine. So I wanted to look at the other side and see how actually I could make a difference in the not-for-profit sector. And that's what actually took me to where I am now. So after 10 years successfully working in the pharmaceutical business, now I look at how actually I can be of support to increase access to quality essential healthcare in the poorest regions of the world.
Yeah, and now you are CEO of DTree. So tell us a little bit about what DTree is, what you guys do.
Yeah.
So
DTree is a digital health organization, and it's probably one of the very first organization using digital health to make the life of people better in the poorest regions in the world. It was a Harvard pediatrician who 20 years ago saw the opportunity of the new technology, digital technology, to actually make a substantial change in the health services in Africa. So if you still walk in a healthcare facility in Africa, in a rural area in the middle of nowhere, you could still look at the walls and you look at the protocols, clinical protocols on the wall, and showing what are the questions, what are the steps for the healthcare workers to treat the patients. And for protocols on HIV, some type of protocols, they can really stick. You can put all the protocols on the wall. For those that are more complicated, and can, for example, the protocols to treat children, the integrated management of children illnesses. This actually, it fits into a book like this. So the idea was, how can we help a healthcare worker that has so many things to run and support a healthcare worker to actually adhere, to be compliant with the clinical protocol, run the clinical protocol, and then make an accurate diagnosis for the sick child. So that was the idea of transforming these protocols into digital algorithms. And this is where actually DTree comes from. The D is not for digital. The D of DTree is for decision trees. And so that is how it actually started. That was 20 years ago. Today, in recognition of that vision, the digital health community gathers every year in a big conference. And after the founder, Mark Mitchell, the Harvard pediatrician, passed away, they decided actually to create an award for the most promising innovation. And every year we celebrate the Mark Mitchell Award at the Global Digital Health Forum around the world. So that is how actually DTree started. 20 years later, digital health, even in the poorest countries in the world, is becoming mainstream. And so it's not rare, it's not unique to see digital health applied in the provision of health services in the poorest part of the world. And there are some NGOs that even use drones to deliver drugs. AI, it's becoming more and more. So today, DTree is an international organization. As you said, our mission is to expand high-quality essential healthcare, mainly in sub-Saharan Africa. We partner with government, like-minded organizations to improve the performance of health system so that people can receive the right care at the right place and at the right time. We work in Malawi, Tanzania, Zanzibar, and Zambia.
So before we started, you said you had wanted to just show a video maybe to just set the stage. So maybe I'll go ahead and share it now. And then if you want to comment as we go, or we'll talk at the end as we go. So let me.
Yes, please.
Mungu alifariki mimi bado mdogo sana, na nililelewa na missionary kule kwetu. Kwenye jamii yangu kuitendea mema kama nilivyotendewa mimi kipindi cha nyuma na jamii. Amuko wananifahamu. Wajibu wangu mimi kama ni mhudumu wa afya, kwanza kuwapa elimu wanajamii kuhusu swala la afya. Majirani yangu, afya ya uzazi, vijana, watoto wachanga na kina mama wajawazito. Baadaye. Haya, nikuletee zawadi. Zawadi gani? Nazitembelea ni 364. Katika kaya hizo ndo nazotembelea katika maeneo yangu. Malaba, mjambo? Hilo. Kwa hiyo wale watoto sasa wamenizoea, wameshaniita babu yao. Kwa hiyo matatizo yote mimi ndo wananiambia babu. Na vijana bale wana mitihani sana. Lakini kiwango ni kikubwa sana. Kwa kusanya, kuwaweka pamoja, kuwapa elimu. Nimetengeneza kuwaweka wazi wao kunieleza matatizo yao mimi yale ninawakabili.
Dada nani? Mtu anaweza akawa katika mfumo wa balehe, anaweza akaona mabadiliko yote yale ya kimwili, anaanza kujiuliza vile vile balehe.
Tena
tuende grupu kutokana tulikuwa hatuwezi kuongea changamoto zetu kwa wazazi.
anakutoa kisaikolojia na kujenga, unakuwa unafunguka vitu vingi.
Mafunzo tunaofanya na babu wangu mimi amenisaidia vitu vingi sana.
Muone unakaingilia.
Jambo. Jambo.
Habari.
Safi. Aliyekuwa ananisaidia ni marehemu baba. Uchovu wa mwili wa mara kwa mara, joto kali na kifua mara kwa mara. Yaani tuseme ilikuwa naogopa kama ile kuumwa mara kwa mara ilikuwa nile, ila alipofika amko kwenye uhamasishaji huu ndo alikuja kunipa elimu kuhusu afya teki.
Wao umeamkaje? Kumekucha.
Afya teki ni mambo ya kiteknolojia, yani wanaita mambo ya kimtandao.
Odi.
Nimefanya kazi na afya teki mwaka 2019.
Sasa mimi naomba mauzuri yako ni mazuri
kwa sababu ni muhimu. Afya teki inaunganisha huduma kutoka ngazi ya jamii, kituo cha afya na kwenye maduka madawa, na kule wanapata huduma bora kwa sababu utatunza kumbukumbu yenye uhakika tofauti na makaratasi.
Karibu.
Ndio. Habari za leo?
Salama, shikamoo.
Kwa hiyo nataka nikupe rufaa uende wapi kituo cha afya.
Amuko alinisaidia, nilienda kupima, alinipeleka kituo cha afya. Nilivyopima niligundulika na TB ya mifupa, patikana na fangasi ya kizazi. Waliweza kuniambia sitozaa tena. Nilikuwa natamani kupata mtoto. Amuko pamoja na afya zaidi ya kupata matibabu.
Mbele, mara.
Anaenda.
Karibu.
Asante.
Najisikia vizuri baada ya Elena kumpa rufaa tibiwa, akapata mtoto na anaendelea vizuri.
Na sitakuja kuzaa tena. Nilivyopata ujauzito nilifurahi kwa kweli. Mwanangu anaitwa Christian Isaac, ana umri wa miezi 7, na pia mtoto wangu ananipa furaha. Mahusiano yangu na mko ni ya kiurafiki, tupo kama kiundugu.
Na dhumuni langu sio kuwa Irene tu, nataka wawe na vijana wengine niibue kama dada Irene. Naamini miaka ijayo watapata huduma nzuri kwenye jamii au jamii yangu naizunguka.
Yeah, so the video, thanks for showing the video. I think this is it's very representative of the current situation in many of the areas where we work. You see distances play an important role. You have a very low number of healthcare workers. So to actually offset part of this, there are volunteers that actually play the role of community health workers or community health volunteers that go and visit households to be able to diagnose early or reach out to people that for a reason would not go to the healthcare facilities. And also it is representative because if you have noticed at the very end, they say in memory of Christian. Christian is actually the little boy that is showed in the video clip, which actually passed away a few weeks after the video clip was shot. And unfortunately, this is what happens in many parts of Africa and other parts of the world, where still 1 million of children die every year for pneumonia. Christian died for pneumonia. There is 5 million of children die every year, and most of them is in the poorest countries for reasons that are avoidable and for diseases that are treatable. So this cannot happen, and this is why we are working in all of that. In Zanzibar, where we have been working for over a decade, actually 15 years, 5 children die every year. It's a very small country. It's 2 million of people. Every day, 5 children dies. And then this is coupled now with other new diseases that were not hitting Africa, like diabetes. Diabetes, surprisingly, is skyrocketing especially in that part of Africa. The latest stat says, I think it's 14% of the population suffer from some type of diabetes. Not to think about then cancer and many other diseases that now are actually hitting. So it's a tough situation. There's a lack of medicine. There's a lack of diagnostics, a lack of infrastructures. And so really the health system is not functioning well. And last but not least, even the statistics that we receive from these countries are not reliable because there are no means to really look at that. So this is actually the current situation, and I think it's important also to see where we start, because also we will see later the opportunity to make a huge difference with the new technology. And in terms of technology, also, I mean, despite the fact that there is a lot of advancements, the mobile penetration now also is getting better, even in Africa. The latest statistics say that almost half of the population is connected. So this is actually gives a tremendous baseline that we can work on. At the same time, it's also the network maybe is not as stable as in the Western world. To give an example, this week Tanzania was hit by a national internet blackout. So even for me to talk to my colleagues, there was actually a big issue. So, and then also in terms of expertise in digital, in IT infrastructure, in AI is very limited. And so also this is something that we need to take into account when we want to work in that part of the world. The politics are always complex. In those cases, I think it's even more complex. And this is also why most of our staff are actually local, because they're the best suited to actually navigate the complex politics of the countries. And then also what we see less and less is a resistance to what is innovation. I think this is a common everywhere. We see it in the Western countries, but it's also in many of the countries where we are. Maybe, yeah, digital is good, but maybe it's not the first priority. And then something that really frustrates me a lot is when people downgrade the massive work that is behind digital. They think digital AI is just an app, and therefore you download it, and that's it. Why it costs so much? And so I think we all know that it's not just an app, but that there's a lot of first of all contextualization, but also it's about maintenance, it's about quality improvement, and all of that. And actually, in the past, we ran an assessment of the cost breakdown of a national scale digital health initiative, and actually the technology part was a small part of the total. Sorry, I'm deviating a little bit but I thought it's also interesting to look at these aspects.
Yeah, I mean, people have a hard time appreciating, the thing of software is free often, right? And they don't realize how expensive software is. And it's like, all I need to do this once. Well, the cost of doing it once is the same as the cost of doing it a million times. It's the same infrastructure, essentially. So let's switch gears a little bit and talk a little bit about what you do in practice. What kind of solutions are you developing? What are the challenges in developing those solutions? What results are you seeing as we go through that?
Yes, of course. And I think, again, the video clip shows a little bit what we do. We design, develop, and put job aid tools. So the smartphone that the healthcare workers had in the video clip. So this is what we do. And that healthcare worker is a community health worker. So it's someone that is not sits in the clinics or in healthcare facilities, but goes household to households to look at the potential sick people, but also for counseling, for raise awareness about healthy behaviors and all of that. It's usually someone from the community who works for the community. So we work with them, and so we equip them, we train them so that they are able to make their job better and faster. As you've seen, thanks to thanks to the use of the smartphone, the person could check, for example, danger signs, be able to do a rapid assessment of a patient and see if there is some potential danger signs that requires immediate referral. Referral is so important because often we actually forget that these are places where going to the healthcare facility, going to a clinic is not an obvious thing. Sometimes it requires hours of walk, or so it's not easy to access. So it is important that when a person is referred for a good reason. And so the importance of this first step, I call it actually the first mile of health. Traditionally, it was called the last mile because it has a more a public health centric approach, but I would like to see it from a person centric approach where it is actually the first mile. And it's also a first mile because it's where actually you start the preventive behavioral change to actually take healthy behaviors. So thanks to this smartphone, it could identify danger signs and refer, could remind about vaccination. Vaccination is also something that is important. Look at what are the vaccines that are taken, and those that are the others that are not on time, or if they are not on time. And then depending on the country, because each country is different, this community health workers can also treat as diagnose the person. Others, they just have to refer to the healthcare facilities or to a drugstore, as in the case of Tanzania, where we saw the video clip. I can do some screening for HIV, for TB. So it really fulfills a lot of tasks. And these people usually are not so well trained. They receive some minimum training. So the use of a smartphone actually helps them to actually make a better work. At the same time, data is collected, is actually reviewed, is aggregated. So then it comes the role of the supervisors that could actually look at district level, look at the area where the community health workers are, and actually allocate them according to the needs. So prioritizing the work according to the needs, and even to pay based on the performance. So it is actually an incentive, and based on, for example, the number of visits the community health worker will receive a certain level of retribution. So this is actually what has been done. And also the connection to the healthcare facilities, connected information. And finally, we also work at the ecosystem level. So because this project are not standing alone, you need to work with the entire ecosystem. So we also support government and government staff to be able to actually co-manage and then eventually completely manage these programs. So it's about raising building capacities among the governments so that they could manage, they could look at, they could store data, they could protect data, to help them develop digital health strategies, to help them digital health data governance, and all of that. So we actually look at the full ecosystem. So this is, in a nutshell, what we do.
How variable are like the rules and the conditions from country to country? Is this every country very different, or is this a relative?
It is surprising. It's but they are usually very different. Every context is unique, and also I would say even in the same country there are massive differences, and there are cultural differences, and then also there are policy differences and technical differences. And I'll give you the example of Tanzania, because I mentioned Zanzibar. Zanzibar is a semi-autonomous region of Tanzania, but they are completely two different worlds. So you go to Zanzibar and they say you see type of culture, and also in terms of also technology is very different. We use a technology in Zanzibar and another technology in mainland in the rest of Tanzania. So yes, it makes a difference, and also workflows are different because also they respond also to some political dynamics, and so. In some contexts, you may have the HIV unit is separated from the family health unit. Sometimes it is integrated. So yeah, they are very different, and they sometimes also differ because of what are the main epidemiological issues.
And I assume that means that the digital applications also probably have to be modified from context to context.
Yeah. So there is not the application that you can download and use it everywhere. You have to actually each time to adapt it. And of course, I don't want to say that they are really unique and there's nothing that you can actually exchange. Actually, there are some parts that actually are common, and actually this we actually leverage that and we build the synergies. So we in contact with other organizations that are in other settings, in other African countries, and we exchange lessons learned, which are really, really valuable. But it's not just downloading and it works.
Mm-hmm. So we're beginning to see more digital health and beginning to see the role of data, artificial intelligence. Where do you see these kinds of technologies having an impact, and what is the initial steps in this area that you're seeing here?
Yeah. So, for example, DTree is a small organization. We are about 70, 80 people around the world, and we work in four countries. But despite the size, this year, for example, we plan to reach 1.2 million people. We plan to actually assist through our programs 1.2 million people. It really shows the impact of digital health as a multiplying effect. So this translates into 1.2 million people this year being able to receive quality healthcare, meaning that if they are referred to go urgently to healthcare facilities, is because that it was actually required. And if they receive some treatments, it's because it was that kind of treatment that was required. So we, in terms of also results, we look at the institutional delivery rate. What is that? So when a pregnant woman gives birth, it's so important that it gives birth in a healthcare facility, where is assisted by skilled health workers. Unfortunately, this is not the case in many parts of the world. So this is a good indicator of how of our results, making sure that that women they give birth in a healthcare facility. And this is thanks to our work, because there is a lot of counseling, there is a lot of assistance before birth, there is a follow-up, and then eventually ladies go and deliver at the healthcare facilities. And so when we started, less than half of women would go to the healthcare facility, and now this is almost 90%. And this 90% both a rural area and in urban area. Urban area traditionally had a very high level of that. Today, also rural area, in the areas where we work, have a very high level of institutional delivery. And now we are actually, because as I said, the power of digital health is a multiplying effect. We actually accelerating the path. And for 2025, so for next year, we actually expect to reach more than 2 million of people served.
Riccardo, as I'm listening to you, thinking about keeping my engineer's hat on, but trying to take it off a little bit, I see two sets of problems here. Let's call them socio-technical. There are sort of social problems and there are technical problems, for better or worse. Which one do you think is a bigger challenge in the real world? Like, is it better human interaction and better human reach, or is it better technology that is the bottleneck right now in your mind? Like, of the two, which one do you worry more about?
So what I see actually is it's very interesting, the reaction to technology. And my experience in some part of Africa is that actually technology is perceived by people, by those people going to the healthcare facility, as actually a sign of quality. Then, be right or wrong, this is another decision. But the impression that they give is that a sign of quality. And in a context where actually a lot of healthcare facilities provide very low quality health services, and this is actually a barrier for many to go to healthcare workers, because they know that they receive a poor quality. The fact that they have a smartphone or a tablet, I mean, it is actually is associated to quality care. So I think this is interesting actually, how actually the impact of technology could actually what could be the impact of technology.
So as you move forward, and again, just to bring it back to the more technical side a little bit, where are the initial AI applications that you're seeing being implemented here? Like, what are the, I don't want to use the word low-hanging fruit because maybe that's a mistake, the most promising, the most exciting things that you see happening?
Yeah, I think there is a tremendous role for digital health and AI in this space. And when I started to work on digital health and AI more than a decade ago, actually there was so much resistance to digital. And I remember I was told by one of the top directors in the previous organization is that there is no space for innovation for an NGO. Let's leave it to other, but this is not it's not for us. And again, the world is changing fast. We saw the impressive penetration now of mobile. So there is a huge hope that this could really we can actually piggyback on this and make a real difference. So yeah, I think the opportunity is there. I think at the same time we have to be careful that I mentioned the 0.5% of the population in Africa has access to mobile phone, but we need also to make sure that the other half actually is not left behind or as we say, left offline. And that the opportunity is huge because you saw Christian in the video clip dying for pneumonia. Do you know how pneumonia today is actually diagnosed in that part of Africa? So basically you count the respiratory rate. So if, depending on the age, if the respiratory rate is over 40, then it is pneumonia, and then you are referred, and then you are treated. Otherwise, you are not. And so you understand that, I mean, a crying baby could have a faster breath. So, and it's also, it's very noisy. It's difficult to really count for a small child the breaths. So the opportunity to make a difference there through technology is huge. And that's why I think actually the opportunity is bigger in this part of the world where the baseline is really, really low. But the fact that the baseline is so low, it doesn't mean that we can actually lower also the quality standards. I think this is very, very important. We can go back in terms of the quality standards and all of that. But back to your point, where I see AI solutions, the most promising AI solutions today is in the clinical decision support for healthcare workers. So, for example, today there are AI-powered ultrasounds that are able to actually diagnose potential problems for pregnancy, during pregnancy. So this is it's a major step. There are AI-powered TB diagnosis based on the chest X-ray. So this is another very successful, already used tools. So, and also other type of much simpler solutions like the one I described at the very beginning, the being able to digitize a complex clinical protocol. It also helps a lot, has a tremendous effect. Then another opportunity is actually chat, conversing with the patients remotely. It's also making big strides into the field. For example, WHO has recently released some guidelines on chatbots for sexual and reproductive guidance. I think being able to use an app to help in terms of building a confidentiality and of a topic that could be a taboo in many parts of the world. So this is actually it's quite it's been had a widespread usage. And also I think it's something like also a resource allocation. For example, we did with Harvard, we did a software looking at how we can predict the risk for pregnancy, a risky pregnancy in women. So meaning that what are the women that require additional support during the pregnancy against others that have probably a normal outcome. So this will help then allocate resources where they are most needed. So risking profile is also widely used. And then another use is actually in the biometrics. So being able to recognize the same patient, and typically for vaccine, where it's important to be able to track patients, this is also widely used. So yes, AI today is widely used in many parts of the world, even in the poorest part of the world. What is important is that we contextualize this, that we make sure that this is for the highest needs. because the temptation to go for the fancy idea is high. And actually, we are in the moment where actually also there are funds for that, because there's a hype, there's excitement about AI to solve big problems. But we need to make sure these are big problems. These are the highest needs for the country. And also they are not isolated, because we can screen so many patients for example, for oncological patients or other type of patients. But then we need to make sure that then we are able to follow up with these patients and treat them, these patients. So it's important that we contextualize and we actually develop solutions that fit for the context, that are also affordable for the context. So yeah, there is a huge opportunity. I think we need to work it. We need to make sure that this is well framed for the countries where we work.
We've gone for about half an hour, so maybe we should sort of wind it down. Was there anything else that we failed to ask that you wanted to talk about, or any last things that you wanted to bring up?
Yeah, I think it's what I'm saying is that DTree will continue to spearhead now AI technology. We really believe that there's a huge opportunity. The needs, unfortunately, are growing. The population is aging. The cost of health is skyrocketing everywhere. So I think there is no alternative really to actually continue to develop technology and ensuring that technology really targets the highest needs in the country where we are. As an NGO, we don't expect to do it alone. And actually, we want to partner, first of all, with the authorities, the local authorities, but also with the international academia like Yale, like others, and also local researchers and the local ecosystem, and also eventually with the private sectors, who also has a big is a big player in the field. Yeah, so we are very committed to continue this work, and it would be great also to continue to exchange with the Yale and see if there are potential collaborations in the future, because we need everyone to support our work and the people that we serve.
Yep. Yeah, looking forward to more discussions. Thanks, Riccardo, for taking the time.